All right, guys, welcome to this week's series on My Health. The USF Black Alumni Society, in partnership with Moffitt Cancer Center, is hosting a week-long conversation on My Health. This is a series conversation on women's health, men's health, fitness and health, mental health, and of course, integrative health. We have one body, and these conversations that will ensue this week is to create a dialogue on how to have more of an integrative versus episodic health. Our panelist today on women's health is Dr. Iman Washington, who is a radiation oncologist specializing in breast cancer at Moffitt Cancer Center. We also have Dr. Audra Williams, who is an obstetrician gynecologist at the University of Alabama at Birmingham Medicine. And we have Dr. Tamara K. Tibby, who's the dental director at Tampa Family Health Centers. I'd like to welcome all of you ladies today and taking time out to share your knowledge and help our community. Welcome, guys. Thank you so much. I feel like I need to clap.
Thanks for having us.
Okay, we're going to start off with our first question that has been posed to us, which is, how do I keep my breast healthy, and what are breast cancer risk factors? And we're going to pose that question to Dr. Iman Washington.
Yeah, it's great to be here. Thank you for having me. So in regards to general breast health, the things that we think about, particularly for risk reduction for breast cancer, and things that you can do yourself, because there are risk factors that are independent of your own activities. But keeping a healthy weight is important. There's an association with obesity and breast cancer. Exercising regularly, exercise and physical activity has been associated with a reduction in breast cancer. Eating a healthy diet, a well-balanced diet. So that's been defined as having 5 to 8 servings of fruits and vegetables per day. Limiting alcohol intake, so increased alcohol consumption has been associated with an increased risk in breast cancer. So alcohol consumption recommendations are limiting alcohol to 1 drink per day. So that means, just because there's always a lot of confusion on what is a drink, right? So a glass of whiskey is not a drink, right? So it's 1.5 ounces of hard alcohol, 12 ounces of beer, or 5 ounces of wine. Not smoking cigarettes. The other thing is, being mindful of keeping up with breast cancer screening. So screening guidelines, while they vary in general, and I think the most popular, acceptance in the US is screening at 40. So that's what I would recommend. In terms of other risk factors, so there are some risk factors that have been associated with very high risks of breast cancer. So like a genetic mutation in BRCA1 or 2, I think most of us are most familiar with, and that carries the highest risk, or a very high risk. Age, which is something we can't do anything about, right? And the older that we get, we have a higher risk of breast cancer. So most women are diagnosed 50 or older. That being said, the breast cancer, mortality rate affects women the most under the age of 60. So that's why screening at 40 has been recommended. And then there's other things like your reproductive history that has a modest risk of, increased risk of breast cancer, like having a period before 12, things like that. Having dense breasts it's not really clear why that's associated with some increased risk in breast cancer, but that's one. Family history is a big one, particularly first-degree relatives that have breast cancer. So that's some risk factors. There's a number of them, so that's not all of them.
Okay. since we're talking about breast health, we're going to move right into, because they're connected, our gynecological health. And one of the things that I wanted to talk about to Dr. Audra is Black women disproportionately suffer from fibroids. What can be done to reduce fibroids non-surgically? Like, what are some of the things that can be touched on? Because I know Dr. Washington talked about like being overweight that can impact. And so I wanted you to touch on like what are some of the things that can be done? Do we need to reduce weight? How we eat, and go from there?
Yeah, absolutely. Thanks for having me today. Fibroids absolutely have a huge impact on women's health, and particularly Black women's health. The numbers show that over 80% of all Black women will have fibroids, whether those are symptomatic that cause them to have pain or heavy periods, or some are completely asymptomatic and don't need to have anything done about them. But it is certainly has a huge burden on the Black health community. We don't really understand why there's this big racial difference. We also know that Black women tend to have their symptoms a lot younger than women of other races. So, we'll have patients in their 20s and 30s coming, needing treatment for fibroids. As far as things that, women can do themselves, certainly maintaining a healthy lifestyle with, a balanced diet similar to what helps with breast health, and maintaining a healthy weight, exercising, because obesity has been linked to fibroids. There's also a lot of research right now into vitamin D deficiency in fibroids, and that potentially playing a role in some of the racial disparities and why there is this difference in the Black community. So making sure that you're having vitamin D supplementation, which is also important for bone health, may be able to reduce some of those issues with fibroids. And just really being aware, I think a lot of Black women feel like they are just going to have heavy periods, and that's just something they have to deal with, and that's not the case. I have patients that come to me, they've had heavy periods, and they're like, okay, I'm 40, I know it's time for my but it's not something that women have to sit and struggle with. We have lots of treatment options that are not surgery. There's lots of medications, whether they're hormonal or non-hormonal, and different things coming out on all the time that can help with treatment of fibroids. But I think the biggest thing women can do themselves is just trying to lead the healthiest lifestyle they can.
It was something that both Dr. Williams and Dr. Washington just said, WW, regarding your weight. And a lot of times where a lot of patients will hear what maintaining a healthy weight, but what is a healthy weight? Because particularly within the Black community, there's also something said about having your curves. But when we hear it within our community, what is considered a healthy weight? Is it using your BMI and going from there? But that would be a question. If you could just allow, both of you can just touch on that slightly.
Yeah, I think that's actually, a really difficult question with, from our medical standpoint, all the studies that we have that say, being obese increases your risk for this, that, and another are all based on BMI, which is, just your weight and your height goes into a formula that creates your BMI. And there's certain specific cutoffs for being overweight or being obese. That being said, I don't think that that's a perfect measure of weight and of health, because we know that weight does not equal health. There are other factors that go into play, but when we're looking at what is a risk factor that makes you more likely to be afflicted with something, all of our studies are based on BMI. So that's most likely what your doctors, your other healthcare providers are looking at and kind of using for counseling.
You want to add anything else, Dr. Washington?
Yeah, so I would echo the same thing. I think one, as far as, breast cancer risk, for instance, a lot of studies looking at, obesity and BMI are done in Caucasian women. So when you look at studies specifically related to African American women, there can be some variability. So I still think that's under study. One study suggesting that a waist to hip ratio may be, something that we should be looking into. So more central obesity may be more meaningful, right, than just your weight, for instance.
Okay.
BMI.
I learned something today. All right, thank you for that, ladies. Next, we have Dr. Tibby. This question goes out to Dr. Tibby. Is how does my oral health impact my overall health?
Well, great. Well, thank you for having me. Can you hear me okay?
Yes.
So a lot of times we don't consider our oral health, but you cannot be healthy without good oral health. And so I'm very happy to be part of this panel to talk about that. So in general, oral health, if you have, healthy teeth, healthy gums, then you'll probably have a better quality of life as well. People that suffer from tooth decay, gum disease, or periodontitis tend to have other issues as well. So there's a lot of overlap between chronic diseases and periodontitis or gum disease, which is like bone loss. So in those situations, like diabetics, for example, people with history of stroke or cardiovascular disease, we're realizing if we can improve their oral health, they have better health outcomes. Diabetics, for example, we recommend that they get regular cleanings in order to avoid having poor glycemic control. And then it's a vicious cycle because if you have periodontal disease, you may have a higher risk for diabetes as well. So it's all interconnected. Chronic diseases are now showing up to have a relationship to the mouth. We're even finding a connection between oral health and Alzheimer's. And then there's overlap with pregnancy. So women who have periodontal disease or severe periodontal disease, they may have a higher risk of having a child who has is born too soon, so premature, and also low birth weight. And then in young kids, we're seeing a lot of kids that don't get their dental needs met. They have a lot of unmet needs. Even in Florida, more than half of the kids that are on Medicaid don't see a dentist each year. A lot of these kids have unmet dental caries, and they have poor school performance because they're having pain from infection and abscesses. So you cannot be healthy without good oral health, and it relates to your whole body. The same blood that goes to your teeth and your gums goes to your heart, goes to your lungs, goes to your brain. So you've got to have good oral health.
All right, thank you for that. All right, I learned something. All right, this one is it was two separate questions, but we're going to combine it. It's like, how does contraceptives, birth controls, impact my breast health? And that question was also asked regarding my gynecological needs. And so I'm going to pose that question first to Dr. Washington and then to Dr. Williams. So the question again is like, how does contraception, birth controls impact my breast health? And then how does it impact my gynecological health?
Oral contraceptive pills, for women who use them for more than 5 years, has been associated with some increased risk in breast cancer. The highest is for women who are current users. After stopping oral contraceptive pills, there's a decline in that risk. And there are a couple of studies that suggest that once you get 10 years out from your stopping, that you no longer have an elevated risk. That being said, so the kinds of studies that are done, the population-based studies that are done, or case control studies that are done in this setting, leaves room for a lot of bias. So that's not a really clear, defined space. For instance, there's evidence that it's not all oral contraceptives, right? Certain contraceptives, like triphasic contraceptives, where the hormones vary throughout the cycle. So that's something that might be kind of a good place for Dr. Williams, but to pick up on.
Okay, and like as you were talking, someone wrote in the Q&A, is like going more specifically, is there a particular type of birth control that would be linked to cancer? But you started to address it, so we're going to turn it over to you, Dr. Williams.
Yeah, absolutely. I think that like Dr. Washington said, the data isn't perfect, and there's been some mixed data out there. I think there were a lot of headlines a few years ago when there was a big article that came out in the New England Journal about contraceptives and increasing risk of breast cancer. But like she mentioned, it's important to look at where those information come from, where those studies come from. That was out of a big Danish study, which may not be applicable to our communities and our patient population here, and particularly the Black community that tends to be underrepresented in a lot of this research as well. But certainly we know that hormonal contraceptives can increase the risk. To what extent, we're not sure, for breast cancer. But it's important to know that it can also be protective against other types of cancer. So women that take oral contraceptive pills decrease their risk of ovarian cancer, colon cancer, and uterine cancer. And so I think it's really important for each patient, if somebody comes to me and says, I heard this can increase my risk of breast cancer, should I get off of my birth control? It's really an individual conversation. What's your family history? Do you have a higher risk of breast cancer in your family? Or no, maybe you have a higher risk of colon cancer, so it makes more sense for you to be on something that's protective against that. And there's also, I think the second part of the question, how do contraceptives impact my gynecologic health? There are so many other just non-contraceptive benefits of birth control as well. We use birth controls as treatments for heavy bleeding. They can be helpful for patients that have polycystic ovarian syndrome, help with their acne, their facial hair growth. There are so many other things that can really be beneficial for birth control. So I think it's an important individualized conversation to have with your own healthcare provider as far as what you're looking for in a birth control and what other benefits or other effects you're looking for it.
While you were answering, someone just came in the chat that said, I know we talked about this earlier, but it was just to retouch on it. It's like, why do Black women get more fibroids more than other women? Is there like a specific, outside of genetics, food, weight?
Yeah, we really don't know. There's a lot of big research networks out there right now, kind of across the country, looking at some of these factors. Certainly, we think there is some genetic correlation. There does seem to be, women whose mom and aunts have had fibroids are more likely to have that as well. Is there a vitamin deficiency like vitamin D that plays a role? Maybe, but really we don't understand it all that well.
Okay. All right, I have like another question. All right, we're gonna get to this. Sorry, my question popped up and I was like, what? But two questions. We're gonna ask this question first. Like, how do you reduce racial disparities in healthcare and like oral care? It's like the question was more of what can I do as a patient to reduce or confront racism I face from those who I need help with to heal? So we're gonna start off with Dr. Tibby, then we're gonna go to Dr. Washington, and then Dr. Williams.
Okay, thank you. It's a good question. So I think a lot of it comes down to, we have an access issue in America, and that's across the board for poor people, minorities, different racial, ethnic backgrounds. So I think it's important to first increase your literacy, like tuning into panels like this to raise your own awareness and knowledge of your health and getting information from the right sources. And then, once you're informed, I'd say seeking out community health centers. I know we take a lot of patients from all backgrounds, all insurances to get access, but basically getting plugged into the system somewhere, finding a real dental and medical home, and finding someone that you can actually trust and whose opinion you value. I think having a primary care physician is as important as having a primary care dentist, a general dentist, to help you navigate. So I'd say, first of all, get informed, read things. There's so much on the internet in reliable sources, National Dental Association, the ADA, even the CDC has information on oral health. And then getting connected to the healthcare system. And if you don't have insurance, a lot of people don't get oral health care because they don't have insurance. There's community health centers. There's also public health institutions that will take you, some free clinics. That should never really be a reason to be a barrier. I would say seek that out. And as far as disparities, they're going to continue to exist. I mean, I think a lot of this starts in education, the foundation of everything. If you look at the income gaps, wealth gaps, it really comes down to people having good education and then going on to second level degrees and so forth, and then that generational wealth. So those are things that aren't going to get solved in a conversation for today. It's more about changing the system overall, but I think knowledge is power, being informed, and staying plugged in and seeking out individuals that you can trust with your health.
Okay. Thank you, Dr. Tibby. Dr. Washington?
That was a really good response. That was really comprehensive. So I think she really hit on all the major points that that I would think to provide some input on. But I guess I would echo you know, being informed, right? And knowing how you should be advocating for yourself and what kind of guidelines exist, as well as, you know, for those who lack insurance, understanding that there are a lot of avenues for individuals without insurance, and in part is looking into it. For instance, you know, where I work, there's charity care, right? That not everyone is familiar with, but we see people who are underinsured. So part of it is being informed about the places that you want to receive your care, what kind of options are available for you. In terms of, you know, providers, it's important to have a provider that you trust and know if there's someone that you feel uncomfortable with, you are entitled to seek care from someone else that you feel more comfortable with. That's okay. So those are, you know, a few things I think to keep in mind. And
Okay, thank you. Dr. Williams?
Yeah, so many great points made. I think that one of the biggest things that we're looking at in my field is the disparity of maternal mortality. Black women are 4 times more likely to die in or around childbirth than white women. And sadly, you know, Dr. Tibby mentioned some of the systemic things of education and poverty, you know, being able to impact some disparities, but we know that for maternal mortality, being educated, being wealthy doesn't protect you. The rates are just as high for well-educated Black women. And I think that, you know, that tells us that our system is broken, and that our, you know, the biases that healthcare providers have and may not even know they have are affecting us. Affecting our patients. So I think the things that Dr. Washington and Dr. Tibby both said about making sure that you have a provider that you feel comfortable with, that someone that you feel that you are being listened to, is really important, because we hear story after story. Even, you know, Serena Williams, one of the most powerful women in the world, tells her story of knowing something was wrong with her after her delivery, and not being listened to, and really having to advocate for herself to ultimately, you know, get a diagnosis of a pulmonary embolism, something she could have died from very easily. And so just, you know, continuing to empower women, and particularly Black women, to advocate for themselves, educating themselves, seeking out providers that they feel comfortable with, and also advocating, sorry, my auto light is going off. Also, you know, advocating for something I think that can help in healthcare settings is protocols and procedures, so that we try to remove biases that come into play. That, you know, every time we see this, we do this. That it's not up to individual decision making in some of these really high risk, you know, things that we come across, especially in obstetrics, that can impact maternal mortality, whether it's dealing with high blood pressure in pregnancy or heavy bleeding at the time of delivery. I think it's really important for physicians and institutions to set up those safeguards so that bias is not as introduced and doesn't affect individual patients as much.
And I think just listening to what all of you ladies have said is that, and there was a question that also came in, like, as in, like, how can we encourage providers to listen to patients more? Is it an issue of racism or something else? But what I think that Dr. Williams just addressed and talked about is, if you create systems within your organizations that anytime you see X, this is what we do. So you take out your own implicit bias. And so that helps to remove those obstacles going forward. And so if more institutions or more independent care providers would do that, I think that would truly help. Did I miss something? Did I say something wrong? No, okay. All right, and if the person who asked the question, if they have more clarifying questions, feel free to put that in the chat.
can I actually add to something?
Go ahead.
I think that it's relevant in regards to breast cancer disparities and screening for individuals. So in 2018, the American College of Radiology was the first to include Black women in their high-risk populations.
Oh, wow.
For breast cancer. So their recommendation is for every woman who's and especially Black women amongst that group to be evaluated for their breast cancer risk no later than age 30, which doesn't mean screening. It just means to be evaluated for your risk. So your provider is going to look into, your family history, reproductive history, that sort of thing, to assess your risk and determine if you are of high enough risk to require either screening prior to 40 or supplemental screening, that sort of thing. And then otherwise average risk women to start screening with breast mammograms at 40.
Okay.
So I think that's something for women to be aware of and to talk to their provider about.
Okay. Another question, since Dr. Washington, you're talking, is going to you, is do you recommend removal of all lumps from the breast instead of, oh gosh, the question disappeared. Removal of all lumps from the breast instead of keeping markers in the breast?
So generally, if you have a marker in the breast, it's because it's been biopsied. And so what is being done is they're leaving a clip in there of where the mass was biopsied. If a biopsy comes back benign, then it's not necessary to remove it. There are some breast conditions that put you at a higher risk for breast cancer and should be removed. But the marker itself is not a problem. More fibrocystic breasts can create lumps. And so it's not necessary some women just have lumpy breasts, right?
Okay.
So it's not necessary just to remove something that is like a known benign entity in the breast.
All right. There's another question that came through in the chat and this is directed to all of you. Do you recommend clinical trials, particularly since Black women are not necessarily represented in the trials that they do? We'll start with, this time, Dr. Williams, Dr. Tibby, and then end with Dr. Washington.
That's a fantastic question. And I think that it's a tough one. I absolutely, to get better data as to how to better treat Black women, we absolutely need Black women included in trials. But I understand, given the history of atrocities that have been inflicted upon Black women, there is a distrust in the system. So I think it goes back to, is this with an institution that you trust that maybe, have had care established with for a long period of time, or is this a provider? I may have a clinical trial that comes through my clinic that I offer to my patients, and I hope that my patients would feel confident that, I wouldn't enroll them in something that I thought was unsafe or would be exploitive of them. So I absolutely think if it's an institution, a provider that you trust, contributing to our medical knowledge and our medical literature is really important.
Okay. Next is Dr. Tibby on clinical trials.
No, I agree exactly what Dr. Williams said. I do think it comes down to the trust that you have in the person who's conducting the trial. Also, are you able to participate? Is there anything that's restrictive in your health condition and so forth? But I definitely agree with what Dr. Williams said as far as the trust of the system. And I can understand people not being willing to participate, like what we have going on with COVID-19 and those trials. There's a lack of representation there, but we need people to step up in order to know if the vaccine would work in our communities. So it's like a double-edged sword. It's needed, but we understand people's hesitation.
Dr. Washington?
Yeah, so I think clinical trial participation is really important because Black women are so underrepresented that the data that exists is being applied to them, although we don't know, specifically if there are any differences. I agree with everything that's being said. I think in terms of, when you're considering, trial participation, particularly national trials, those are very well-designed trials, well thought through trials. Those are meant to apply to large populations. And I think that's, I think those are very reasonable and should be encouraged. Some of the, smaller trials that may be pretend some like higher risk then maybe would be encouraged on a national trial. I can understand some hesitation there, but certainly I think national trials are very important. And the other thing, you know, I talk to my patients a lot. We have several, you know, breast cancer trials open at Moffitt. And I just encourage you to ask questions, right? And to really understand why it's being done, what the potential risk and benefits are. So I'll take as much time as I need if someone is interested in a trial, and so they know what's available to them, to really understand, you know, what the point is and what it's going to entail for you. There are also clinical trial coordinators that can talk to you further about some of the details and logistics to see if that's something that would make sense for you.
Okay. I just wanted to give you some feedback in the chat that's going on right now, is that what we were just discussing is saying to you guys, the panelists, the doctors, is giving permission to African Americans to switch doctors is huge. Too many of us feel as if they have to stay with the doctor just out of loyalty, even when the doctor is giving advice that is outdated, especially to our elders. And so having this conversation of speaking out, saying that if this is not working for you, you need to move on to something else. So I want to thank you ladies for saying that. The next question we have is going back to regarding fibroids, and this particular person is contemplating surgery. Which one of the following options preserve my reproductive health with the least amount of trauma to my body? The exablate treatment, which is the MRI focused guided ultrasound, UAE, which is the uterine artery embolization, or myomectomy. And so obviously that's going to Dr. Williams.
Yeah, another fantastic question. And I really think it depends on what your goals are. So those are all going to be procedures that maintain the uterus. So that's kind of one of the biggest things we ask when we're treating fibroids. Is this somebody that wants to maintain their uterus for reasons of fertility? They would still want to be able to get pregnant in the future. And certain types of fibroids can impact fertility. Or there are other reasons why someone may want to reserve their uterus, whether that's a cultural reason or their own personal beliefs. So the MRI focused ultrasound, or the exablate, and the uterine artery embolization are both procedures that are performed by radiologists and not gynecologists, that either focus radiofrequency energy or actual, like, use little particles to cut off the blood supply to the fibroids. And they have both been shown to be successful at shrinking fibroids as well as decreasing the bleeding symptoms that women have from fibroids. Those procedures have less downtime than something like a myomectomy that is a little bit more of an invasive surgery. And so if you are looking to have a quicker recovery where you won't need to be off of work as long, then I think one of those options would probably be the best. And then the other thing to think about is kind of what are the long-term outcomes of any of those procedures. The exablate has been around the least time of those, so we don't have a ton of long-term studies, but in what we do know, there's about a 12 to 20% risk of you needing some other sort of treatment for your fibroids in the future. That's pretty similar to the embolization. About a quarter of women will still need something else in the future, whether that's a myomectomy or whether that's a hysterectomy. And with myomectomy, those rates tend to be a little bit lower. None of them are 100% curative of fibroids. The only absolutely definitive management that we have is, unfortunately, hysterectomy, which is a more invasive procedure and does, that does limit fertility, absolutely. But there are, we don't have enough data as far as if somebody was looking to get pregnant after one of those procedures. The data is a little bit mixed as far as embolization. There are some radiologists that would say, yeah, it's fine for you to go get pregnant. If you talk to an obstetrician, they'd probably be a little bit more hesitant about somebody getting pregnant after an embolization. And we certainly don't have enough data just because it's a newer procedure for the exablate. So it really depends on what your individual goals are, what you're thinking about in terms of recovery. And, if you absolutely want to reduce the risk of needing another procedure in the future, that can kind of guide you which way to go.
Okay. All right. We have a couple of questions that came in through the chat. We're going back to regarding clinical trials. And this is going towards Dr. Washington. Are there many clinical trials for triple negative breast cancer patients?
That's a good question. For those who aren't aware, so triple negative breast cancer is a more aggressive type of breast cancer, and Black women are more likely to be diagnosed with triple negative breast cancer than white women. So for trials,
I'm sorry, before you
yeah,
go further into your explanation, could you explain to those who are ignorant what triple negative breast cancer is?
yeah. So breast cancer has different subtypes. It's based on looking at whether it's estrogen receptor positive, progesterone receptor positive, or overproduces the HER2 new protein. So that's when you hear, ER positive breast cancer, HER2 positive breast cancer, that, those sorts of things. So triple negative means that it doesn't have those things. The implications of that tends to be a more aggressive tumor. There are generally, compared to estrogen receptor positive disease, less treatment options kind of overall. So there are treatment options, but just in terms of the sheer number, it's not the same. So in regards to clinical trials specifically for triple negative breast cancer, there are not, so we have trials at Moffitt that are open in the medical oncology space. So that is related to medications for breast cancer. And the radiation oncology space, while we have multiple national trials open that enroll women with triple negative breast cancer, they're not specifically for that reason. They're looking at other endpoints. I do anticipate, though, that we will have a protocol coming out of our department that's specifically for women with triple negative breast cancer in the near future or so.
Okay. We're going back to you. Another question came through for you in the chat. It's like, if a woman has a family history of breast cancer and they have the gene, do you recommend that they have a double mastectomy?
As in they're BRCA positive, presumably?
They didn't say.
Okay.
I'm hoping that they can hear this and respond quickly.
Okay. So in terms of just having a family history of breast cancer,
the answer is yes, they do have the BRCA positive, yes.
Okay. So I'll kind of answer that in kind of a two-step. So in regards to just having a family history of breast cancer, that's not a reason to undergo a double mastectomy. While there are familial susceptibility genes for breast cancer, just because there's women in your family with breast cancer, doesn't mean that you have a known genetic mutation. So that would be something to, again, when you undergo your risk assessment with your provider, there are models that can provide a percentage risk, and that helps to determine whether or not you should undergo screening earlier, that sort of thing. So in terms of having the BRCA gene, so that is very much an individual decision. That is an option to undergo a bilateral mastectomy, which a lot of women will do. There's other screening guidelines for those women because they're considered high risk. So you don't have to undergo a double mastectomy for those who want to maintain their breast. If a breast cancer is found in that setting, a breast conservation therapy, if otherwise possible and reasonable based on the cancer that's diagnosed, is an option for those women. But we do talk to them about the option of a double mastectomy based on just a high lifetime risk of breast cancer.
have quite a few questions rolling in. But speaking of breast cancer, but actually this is posed to Dr. Williams or a combination of Williams, Washington. How does that, if I'm diagnosed with breast cancer, how can I preserve my reproductive health? I guess that would be more for Dr. Williams, or maybe both or combination. But I'm going to start with Dr. Williams.
Yeah, we have some guidelines for gynecologic care for women with a history of breast cancer. It's certainly, you would have your treatment plan and your breast cancer screening that would be, managed by your oncology team. But from a GYN standpoint, there are some things, depending on your age, different hormonal medications that you may or may not be recommended to be on that can certainly impact your reproductive health. Some of those medications have, menopausal side effects like hot flashes and vaginal dryness that we then can work through and treat from the GYN standpoint. I think there are certainly for women that have a, family history of breast cancer or breast cancer survivors themselves. And if they are still of reproductive age, there are lots of conversations to be had around contraception and what would be safe birth control methods for them. So those are kind of some of the things that, that we talk to patients about and have to counsel about with the diagnosis of breast cancer.
Dr. Washington, you want to add anything or you're okay?
I think I'm okay. Yeah, okay. I don't have a whole lot to add.
All right, next one, which impacts all women. What constitutes a healthy vagina and how do we keep it healthy as we age? I'm going with that.
I love this question. Yes, all the vagina talk all the time. I think that, some recent songs and music videos have kind of put this to the forefront as to what constitutes a healthy vagina. And yes, discharge is normal and a dry vagina is not normal. So we can just put that out there. But, I think a lot of times women, we get the sense that our vagina has to smell like a flower and like be this perfect thing, but the vagina is a self-cleaning oven. If you have any takeaway from today, that is what I want you to take away, is that the vagina will take care of itself. We have good bacteria that keep a balance of our natural pH in our vagina, of the amount of moisture in our vagina. Not all odors of the vagina are bad. But things that can be, something that you may want to talk to your provider about if your discharge changes. So does it have a different color? Does it have a different odor? Is it associated with itching or burning? That is not normal. And that's something that needs to be looked into. You really don't need any products for your vagina. I know there's a lot out there. There are a lot of, companies that are selling you things and jade eggs and all this stuff, but leave the vagina alone. Douching is a big no-no. It just throws off your pH. It just causes problems. So leave that to your grandma. Don't do that anymore. Using unscented, undyed, any sort of, soaps, fabric softener, all that sort of stuff. The less dye, the less scent it has in it, the less likely it is to irritate the vulvar and vaginal region. Sleep without underwear, let it breathe. Those are kind of big vulvar vaginal hygiene tips that I would give to all my patients.
Oh no, you started the vagina monologue. So we have another question that came in. Are frequent yeast infections after intercourse normal? If not, what might be the underlying causes?
Yeah, no, definitely not normal. Something that you should talk to your healthcare provider about. There's lots of, reasons that women can get yeast infections, depending on your menopausal status. Sometimes frequent yeast infections can actually be a sign of another health problem. Women that have diabetes that may not be diagnosed can sometimes present with just recurrent yeast infections because their blood sugar is uncontrolled. So certainly something you want to see your healthcare provider about.
And continuing on with the vagina monologues, the next question is, so the Refresh product is okay or not? How do you rebalance your pH in your vagina? Yeah,
Refresh is an okay product. It its goal is to reset the pH. So that would be if somebody does have recurrent like bacterial vaginosis, which is where the pH of the vagina is off and, you know, causes odor and discharge due to an imbalance in the bacteria that lives in the vagina. That is something that I do, you know, recommend, but it's not something that needs to necessarily be maintained. It's to treat a problem. But outside of that, it'll take care of itself.
Okay, so we're moving away. I don't see any more questions right now about our vagina. So we're moving on to our next question, which is, how will menopause impact my breast health, gynecological health, and oral health? For this week, round robin, we're going to start off with Dr. Tibby, then we're going to move on to Dr. Washington, and then ending with Dr. Williams.
Hi, Erica. So for menopause and the oral health, some women do experience like a burning mouth syndrome when they reach menopause. So I definitely first say, make sure you have a dental home, see a dentist regularly, because, you know, changes occur when we have a baseline. So knowing what your normal is will be important to then see what's abnormal. So also some medications that women may take may cause dry mouth, so xerostomia, and that puts you at a higher risk because your mouth should be a moist environment. You need your saliva to clear any food that you're eating, and also to break down the plaque on your teeth so that it's not just staying there. You want things to kind of be flowing and cleansing. It's not self-cleansing, but flowing and cleansing. So if that changes, you're more at risk for having caries, so dental decay. In addition to that, as you get older, you tend to lose like bone, which is natural throughout the body, and also in your mouth as well. So you are more prone to have your roots of your teeth become exposed. And normally your roots are covered by bone, which is covered by tissue. In this situation, when bone goes away, you also lose the tissue. So you're more likely to have exposure of the roots, and then you're more prone to get root caries. And that's a more aggressive form of caries because your roots aren't supposed to be exposed. And when they are, it's thinner cementum material that's very thinner. So you're more likely to get a cavity there that gets in tunnels a lot faster. So overall dry mouth, xerostomia, and other issues can arise. So it's important to have a dental home so we can address that, looking at replacements for your saliva if needed, and then layering in other preventative things like more frequent cleanings and checkups, and then also recommending fluoride treatments or at-home use of fluoride to counteract any increased risk for caries that you may have.
Okay. Dr. Washington, and just FYI, I know we're about 15 minutes away or 13 minutes away, and I have like 7 more questions to ask live in the chat. So not trying to rush you with your answer, but I got questions to ask, more questions for everybody. Okay, sorry. I just had to put that out there.
So with menopause, it's normal to have a change in your breasts and, you know, the breast becoming less dense. And so there's no issue with that. That's completely fine. That's normal. And otherwise, I think being good about your undergoing your breast cancer screening, considering the association with age and breast cancer diagnosis. So I think those are 2 big things.
Okay, thank you.
And as far as gynecological health, obviously lots of impacts of menopause from that standpoint. So, you know, menopause women automatically associated with hot flashes and mood swings. Those are not universal, but they are very common. They are also not something that you just have to deal with. There are management options for those, hormonal versus non-hormonal. There's also an increased risk of osteoporosis, so it's important for postmenopausal women to make sure that they've been screened with a bone density scan at some point. Again, it depends on your family history, your personal history, but all women need to be screened at least once in their lifetime.
Okay. We're going to go over to Dr. Tibby. How do you whiten your teeth naturally, and how do you keep your mouth naturally fresh?
Okay, so I would first start off with this important, you know, diet's important, nutrition's important. And as far as like keeping your mouth naturally fresh, I would definitely recommend brushing at least twice a day. So morning after you've had breakfast and at night before bed, and then not eating anything afterwards. And for those that struggle with fresh breath, I would say add another brushing after any time that you eat. And don't forget to brush your tongue. So as far as natural whiteners, I mean, I've seen some things that talk about peroxide. So there are toothpaste that have peroxide in them that you can use. You can use, regular peroxide, and I'm not going to make up a concoction, but you can add peroxide to pretty much anything that would be like a whitener. But I'd recommend, if you really want to have a lasting effect in tooth whitening, that you see your dentist first, because sometimes you may have open holes in your teeth that need to be fixed before you try to use those types of products. So getting a good checkup, making sure you have no cavities, and then they can give you a whitening tray that you can use at home safely, rather than trying to do a DIY. And then the last thing, if you are doing any whitening, you should use a straw. So if you're drinking anything that stains your teeth, it's going to pick right back up. So drinking those dark liquids through a straw, your teas, your grape juice, would be important to keep your teeth white.
Okay.
But nothing beats brushing.
Beats brushing. Oh, and flossing. Yes.
And flossing.
Okay, combination question for Dr. Tibby and Dr. Washington. Then we're going back to Dr. Williams with the vagina monologues. I'm going to move your questions together. But Dr. Tibby/Washington, is it true to not use fluoride toothpaste when going through chemo treatments?
Oh, wow. So I have never heard that before. I would recommend fluoride because, fluoride's a natural element. It's safe. I know there's a lot of anti-fluoridationists out there, but it's safe. It's effective. It's been around for over 55 years, and it's been used safely in the right dosage. So we actually recommend fluoride and do prescription fluoride toothpaste for those who are going through chemotherapy, because again, your mouth is dry, you're at higher risk for caries. It's one way to kind of combat that. So I don't agree with that. If someone has additional research that's come out to show me, I would take a look at it, but I believe it's indicated.
Dr. Washington, do you have anything else to add?
Yeah, I wasn't familiar with that either. I think one thing I'll add, just because I'm a radiation oncologist, so one thing that I hear from a lot of my patients, particularly those who need to do dental work around the time of their radiation, is is my breast radiotherapy going to prevent me from getting dental work? Where that's coming from is radiation therapy to the head and neck area into the mouth does carry risk, like dental risk. However, with breast radiotherapy, if there's nothing unique about your case, that if you have a local regional disease, meaning that everything's like from the neck down, there's not going to be issues with you having dental work. But obviously it's reasonable to talk to your radiation oncologist about it if you have any concerns.
Okay, I'm going to pause before going back to the vagina monologue. And since there was another question regarding toothpaste, it's like, what toothpaste do you recommend when you're taking antibiotics for people who have chronic disease and going to the dentist for cleaning? So is there something that you recommend for that?
So I always recommend toothpaste that has fluoride in it. So I know the previous question was asking about fluoride. So fluoride has a lot of beneficial effects, and it's mainly topical. So when you brush your teeth, it's going to give a topical effect. It actually can kill bacteria. It strengthens and hardens your teeth. It can help to remineralize your teeth. So any toothpaste that has fluoride in it is what I would recommend. And then as far as antibiotics, I think maybe the question may have been mixed up. Sometimes before you see a dentist, you need to take antibiotics. People that have heart disease, for example, or joint replacement, you're going to need to take that medication, because we talked about it, the same blood that goes through your teeth and gums goes to those other parts of your bodies, and so the bacteria in your mouth can travel. So if you had a heart condition that requires antibiotics, you'd be prescribed that by your physician, or sometimes we do consultations with them and we prescribe it ourselves for patients. So I'm believing that maybe what the question could have been. If it's not, if they want to put it in the chat, I'll answer it a different way. All
right, not a problem. I'm going to go back. I said we're like 7 minutes down. We have several more questions. I'm not
around.
Okay, so for Dr. Williams, what may cause bleeding during intercourse? I have seen my GYN for a year with no answers except recommendation for birth control.
Yeah, lots of different things. The cervix has a lot of blood supply to it, so it can be very sensitive. Sometimes just your natural anatomy, you can have what's called, the cervix kind of has two parts, the inner part and the outer part. And if more of the outer part is just kind of what your anatomy is, then the friction of intercourse could just cause you to have bleeding. There could also be something like a polyp on your cervix that hopefully your physician did an exam and took a look, that can cause bleeding. Infections can cause bleeding after intercourse, so you want to make sure you've been screened for infections like gonorrhea and chlamydia, because they can lead to that as well.
Okay, thank you for that. Next up is, and I guess this goes towards all of you, is it's hard for me to find a good primary care doctor of color or doctor that will relate to women. Is there a list of AA primary care and specialist doctors in this area? And I'm not sure which area this is. I'm assuming they be in Tampa, but I'm down here in Palm Beach. So is there, and Dr. Williams is in Alabama. So I don't know what area it is. The question in general is there a list of doctors of color in your related fields, dentistry, gynecology, radiation, oncology? Is there a list of that? Yes or no? Or where can they go to look that up?
So for radiation oncology, I'm not aware of a list. There's not that many of us, so that would be pretty hard to find, honestly.
Okay.
So I don't have an answer to that. What I would say is there are Black physician organizations, so you may start there and see who's listed there in your community.
Yeah, I was going to say the same thing. So the National Medical Association is kind of the large organization for Black physicians in America. And so that may be a good place to start. I'm not sure if they have any sort of database for Black physicians based on region or location, but they may be able to guide somebody in the right direction.
Okay.
And I'll piggyback and say the National Dental Association, they have local chapters. I'm in Tampa, so Tampa Bay Dental Association would have that list and those resources.
Okay, so in this few minutes that we have left, we're going to answer one question, and then we're going to do a round robin of your last thoughts that you would share. So from your perspective, speak to the various life stages of going from a young woman to a seasoned woman, because my dad chastised me for saying old, for a seasoned person. But based from a woman going from prepubescent all the way to being seasoned towards end of life, what should I expect from my breast? What should I expect from my gynecological needs? And what should I expect from my oral needs? And just giving like a summation of that. Does that make sense? I know that's a lot in a short. And I'm asking you from cradle to grave. What should I expect based on, but condense it to like a minute. I know it's a lot. Wow, everybody's quiet.
I guess I can. I mean, it's just tough. I think for adolescents, whether it's your daughter or anybody else, just having conversations, important to know, what to expect. What is starting your period going to be like? What are those physical changes that are going to happen? I think in kind of middle life, the biggest thing is for a lot of women is just reproduction. What is your family plan? Do you need to be on contraception? I think, if you're not planning on getting pregnant, you should probably be on something to help you get pregnant. But, kind of what are your reproductive goals? What's your reproductive life plan in kind of those middle years? Making sure that for younger women, HPV vaccine, please, please, please get your daughters and everybody vaccinated against HPV. The younger you get it, the more effective it is. So get them at age 11 when they're eligible for it. And then moving through menopause, we kind of talked about that, expectations for when your period stop, hot flashes, mood swings, and then postmenopausal, thinking about your bone health, and keeping up with kind of your health screenings throughout is really important.
Okay. I know Dr. Tibby and Dr. Washington is left, but we have 2 minutes. So we just no pressure. Go ahead, Dr. Tibby.
I'll go quickly. So the same teeth that you have as an adolescent, you're going to keep for a lifetime. So I would say just remember to treat them well, eat properly, floss, brush, use fluoride, and keep all those things in mind. These are all nutrition related things, healthy mouth, healthy body. So make sure you have a dental home. The same person you can see when you're 12, you can see when you're 80. So find someone that you can trust, establish with them. It could be for a lifetime. And you don't have to lose your teeth. That's not a normal thing. These are all preventable diseases, gum disease, tooth decay. So just staying plugged in and prioritizing your oral health is important throughout your life and phases.
Thank you. Dr. Washington? No pressure. Go ahead.
Yeah. Typically, younger women are going to have more dense breasts, and that's normal, and will become more fatty, with age and after menopause. So that's all normal in terms of, should you know what your breasts feel like? If you look at breast cancer screening recommendations, most organizations don't have a specific recommendation for doing, self breast exams, stating that there's inadequate evidence to suggest that that's going to make a difference in terms of breast cancer outcomes. But it is reasonable to know what your breasts feel like, to know what's normal, so that you can tell your provider if there's something new, and they can do a clinical breast exam. And otherwise, get your screening, get your, tell your, if you're younger or if you have a daughter, risk assessment at 30 to determine when you should start screening, and if you have an average risk, to start breast cancer screening annually at 40.
All right. Thank you, ladies. And I'll say, and the questions that were left in the chat, I will ask the doctors during our recap, and I'll send the response out with the thank you. I appreciate these wonderful women for joining, Dr. Washington, Dr. Williams, Dr. Tibby, for sharing your knowledge on women's health, and you, the audience, for joining. So if you're watching it in the recap, we also have 4 more episodes that are coming this week, same time from 12:30 p.m. Eastern Standard Time to 1:30 p.m. So we hope you join. And if you have any other questions, thank you, and thank our partners, Moffitt Cancer Center, for helping us put on the My Health series. Thank you guys very much. Have a wonderful day. And take care.
Thank you.
Bye.
Bye.